General principles of pharmacology. Distribution of drug. Via the circulation, the absorbed drug can gain access to varying extents to all parts of the body. The dispersion, which begins with the escape of the drug through the walls of the blood vessels and ends with the penetration of the drug to the sites of action, is known as drug distribution. A drug is not usually specific for a particular tissue and therefore will reach some tissues. The extent of distribution to the tissue varies widely from drug to drug. Physiochemical factors. Once a drug has entered the bloodstream, certain factors which tend to decrease its active concentration come into operation. These will be discussed under the heading of protein binding of drugs, accumulation and storage in the body, and drug dilution in body water. The drug can leave the circulatory space by diffusion through lipid membranes or via the large slot-like openings which allow the passage of albumin, so all but the largest of drug molecules, for example, dextrans 70-kDa, can escape from the blood readily and rapidly. For this reason, all but the very largest drug molecules can distribute throughout the extracellular fluid, ECF. The speed with which plasma and ECF concentrations of free drug approach equivalence depends initially on the degree of vascular perfusion of the tissue. Equilibration is rapidly achieved with the heart, liver, kidneys, and brain in comparison with skin, bones, and depot fat. Even after allowing sufficient time for diffusion equilibrium to be reached, differences in drug concentrations in different parts of the body will still be found. These arise due to the operation of those factors earlier, for example, ion trapping, differences in binding affinities or capacities, and the presence of active transport mechanisms between some compartments. The lipid-soluble, the non-ionized fraction is shown as being in equilibrium between all the body compartments. However, although there is a free bound equilibrium within each compartment, the total concentration of drug can differ widely between the compartments. There can be significant pH differences between compartments, which allow widely differing ionized, non-ionized ratio. As there is an equal concentration of non-ionized drug in each compartment, the pH effect produces different concentrations of ionized drug from one compartment to the next, so that the total amount of free, for example, active drug, ionized plus non-ionized, can vary between the compartments. Plasma concentration of drug. The plasma concentration of the drug means the concentration of the free form of the drug. The concentration of the drug in plasma represents the drug that is bound to the plasma protein and the drug in free form. It is the free form of drug that is distributed to the tissues and fluids and takes part in producing pharmacological effects. The fraction of the total plasma concentration of the drug which is free is termed alpha. The factors that control the alpha are the concentration of plasma protein, and b. the binding affinity of the plasma protein for a drug. The alpha increases as the concentration of plasma protein decreases. This increase is more marked in the case of severe hypoalbuminemia. However, the concentration of free drugs always equilibrates with the tissue component. When the concentration of plasma protein is increased, the amount of alpha will be decreased but the concentration of free remains the same due to equilibrium with larger tissue stores. The concentration of free drug in plasma does not always remain the same level following single administration by different routes. After intravenous injection, the plasma concentration of a drug falls sharply. But in the case of sublingual administration, there is a sharp rise in the plasma concentration of the drug and then falls gradually. The plasma concentration of the drug following oral or intramuscular administration rises and falls gradually. The rising phase of the drug is due to absorption and the falling phase is due to distribution, biotransformation, and excretion of the drug. While the drug is administered through the intravenous route, there is no phase because there is no absorption of the drug. Protein binding of drug. A variable and other significant portion of absorbed drugs may become reversibly bound to plasma proteins. The active concentration of the drug is that part that is not bound because it is only this fraction that is free to leave the plasma in the site of action. There is a dynamic equilibrium between the bound and free drug fractions. In this way, the bound drug can be regarded as a storage depot. A single dose of the antitrypanosomiasis drug Suramin can give protection for up to 3 months. A practical consequence of binding to plasma protein is that the toxicity and activity of drugs that are normally highly bound are greatly increased in hypoproteinemia. Similarly, the free concentration of a highly bound drug can be increased by administering a second drug that has a greater affinity for the same binding sites. This is one mechanism by which drug interaction toxicity can and does occur, especially when the displaced drug is extensively protein bound, for example, the displacement of warfarin by phenylbutazone. Drug binding in the circulation is usually but not exclusively to plasma albumin. For example, binding to blood cells and alpha acid glycoprotein does also occur. The bond is usually freely reversible and is of the ionic, hydrogen, van der Waals, or hydrophobic type. The amount of drug bound can exceed 99%, for example, with phenylbutazone, or can be virtually nil, as with amino antipyrine. Albumin is capable of both high-affinity low-capacity and high-capacity low-affinity binding. Volume of distribution. To be effective, the drug must attain and maintain an adequate therapeutic concentration at its site of action. A knowledge of its volume of distribution, VD, enables one to calculate the dose to be administered initially and subsequently to achieve these ends. The volume of distribution is measured by injecting intravenously a known amount of drug, and determining its total concentration in the plasma, both free and combined, after some time, adequate to allow its dilution into the part of total body water into which it can gain access. VD equals amount of drug injected intravenously divided by the total concentration in plasma at time t. In practice, however, when a drug is given therapeutically, the equilibrium is commonly not attained because, before absorption is complete, the opposing processes of metabolism or excretion have come into play. The drug is distributed into the body fluid and delivered to the tissue to different extents. Thus, the concentration in the plasma may not represent the concentration of drugs in other parts of the body. The apparent volume of distribution in an artificial but convenient mathematical concept relates to the amount of drug administered and its apparent dilution in the body fluids as evidenced by its concentration in the blood. So, VD generally refers to the size of the total amount of drug within the body if it presents throughout the body in the same concentration found in the plasma. Biological half-life. Biological half-life is the time taken for the concentration of drug in the blood or plasma to decline to half of its original volume or the amount of drug in the body to be reduced by 50%. It has two phases: half-life of distribution, alpha half-life, and half-life of elimination, beta. Half-life. A half-life value can be readily determined for most drugs by administering a dose of the drug to a subject, taking blood samples at various time intervals, and then assaying the samples for drug content. For example, the blood content of drug A is 8.6 mg per milliliter at 10 minutes and 4.3 mg per milliliter at 60 minimum. So, the half-life of that drug is 50 minutes. The drug A at the dose of 1 mg is injected intravenously, and blood samples are taken at a specific time interval. Each sample is analyzed for its plasma concentration. If these concentrations are plotted against time on linear graph paper, then an exponential curve is obtained. A straight curve is obtained for the same data if the blood concentrations are plotted against time on semi-logarithmic graph paper. This is the characteristic of the first-order process, meaning that the drug disappearance rate at any time is proportional to its concentration at any time. If the elimination of a drug follows an exponential process, the period during which the drug falls from one concentration to one-half this concentration is called the half-life. If the straight line is extrapolated back by y-axis, the concentration of the drug in plasma immediately after injection can be determined, approximately 10 mg per milliliter. One-half of the initial concentration is 5 mg per milliliter, and the time it takes for the plasma concentration to fall to this level is approximately 50 minimum. This is the half-life of this drug. The knowledge of half-life is clinically useful for drugs such as morphine, theophylline, and phenytoin whose concentrations are closely related to their pharmacological effects. The half-life can be used to predict the time to active minimum effect. When such a drug is discontinued, the fall in response can be anticipated. Accumulation and storage in the body. Certain drugs tend to accumulate at subcellular structures. For example, the acridine dyes are known to enter nucleoprotein, while many drugs exert their action on the mitochondria. While some drugs, either fortuitously or by design, become concentrated at their site of action, for example, the mercurial diuretics in the kidney and iodine in the thyroid, this is not always the case. On one occasion, the body is unable to distinguish between normal and undesirable agents, for example, the sequestration of strontium-90 and lead in bones in place of calcium. Chelation by calcium is one mechanism by which drugs can become stored in teeth and bone, for example, the tetracyclines. The antimalarial drug mepicrin leaves the plasma in a matter of minutes and accumulates within cells to reach concentrations up to several hundred times that of the plasma. In recent years, attention has been focused on agents which can persist in body fat depots, as periods of starvation or inappetence could result in their release, consequent toxicity problems. Dissolution is a common occurrence with highly lipid-soluble compounds, for example, the volatile anesthetics, but long-term persistence requires, in addition, the non-volatility and chemical stability, for example, the organochlorine pesticides. The fact that griseofulvin is deposited in the keratinizing epithelium is the basis for its value in the treatment of ringworm infection. Drug dilution in the body. By no means do all drugs diffuse throughout the total body water. The volume of distribution of a particular drug refers to that portion of total body water that is capable of entering. Large molecules are almost unable to leave the plasma, for example, the plasma volume expander dextran sulfate. Many polar drugs are limited. The lipophilic agents distribute throughout the total body water, some so rapidly and evenly that they can be used to estimate its volume by dilution after intravenous injection, for example, amino-antipyrine. Approximately 70% of body weight, fat, excluded, is water. The contribution of depot fat to total body weight varies considerably from individual to individual. About 2/3 of body water is intracellular. Extracellular water exists in 3 compartments: plasma, interstitial and transcellular fluids. Physiological barriers to distribution. There are some specialized physiological barriers in the body. For this region, the drug will not be distributed uniformly in all the tissues. The blood-brain barrier is one example. But further barriers occur in the placenta in the secretory epithelia, intestinal barrier, serous membranes, milk. The effect of the barrier can be the total exclusion of certain drugs. Blood-brain barrier. This barrier exists between the plasma and the extracellular space of the brain, while the blood cerebrospinal fluid, CSF, barrier occurs in the choroid plexus. Most of the drugs cannot enter the brain, while some drugs can enter into and produce either stimulatory or inhibitory effects. From these observations, the concept of the blood-brain barrier has been established. The endothelial cells of brain capillaries differ from those of most other capillaries in that they appear to be highly joined together and there are no intercellular pores and pinocytotic vesicles. Whether a drug can easily pass through the blood-brain barrier depends on the following factors: a. Low ionization at plasma pH, b. High lipid, water partition coefficient, and c. Minimal plasma protein binding. An example of a drug that crosses the blood-brain barrier is thiopentone sodium. It easily enters the brain and produces its depressive effect immediately after administration. On the contrary, highly ionized drugs such as benzylpenicillin cannot cross the blood-brain barrier. But in the case of meningitis, the permeability of this drug through the blood-brain barrier is increased and is useful for the treatment of disease. Dopamine cannot enter the brain due to its inability to cross the blood-brain barrier. So, it is not used for the treatment of Parkinson's disease. But its precursor dopa can easily cross the blood-brain barrier and then be decarboxylated to dopamine within the brain. Placental barrier. The placental barrier has the general properties of a lipid membrane and allows the transfer of non-ionized drugs with a high lipid water partition coefficient by a process of sample diffusion. This means that most drugs that are well absorbed from the alimentary tract, and drugs that can cross the blood-brain barrier can easily enter the fetal circulation through the placental membrane. The transfer of drugs from maternal circulation to fetal circulation through the placenta is responsible for any adverse effects. Alcohol, morphine, or other CNS depressants should not be administered during pregnancy. The administration of drugs such as cortisone, streptomycin, antineoplastic drugs during the first trimester of pregnancy produces malformation of the fetus. The drugs in the ionized form in the maternal circulation do not cross the placental barrier. Drugs with high molecular weight, rapidly metabolized by placental enzymes, and highly bound to the placenta do not readily cross the placental barrier. Intestinal barrier. When antibiotics are given orally, many of them are not absorbed into the system in therapeutic concentrations. Streptomycin and neomycin are examples. The reverse may also hold. Serous membranes. Some antibiotics such as penicillin will not readily pass either way across the pleural or peritoneal membrane. Order of kinetics. Drugs are used for the treatment of disease, but the mode of administration of drugs is different. For example, atenolol is administered once daily dose, whereas paracetamol needs to be given 3 times daily. Morphine is more effective in the intramuscular route, and insulin is in the subcutaneous route. The mode of administration is devised based on absorption, distribution, biotransformation, and excretion of the drug. Drugs usually follow 2 processes for their pharmacokinetic behavior in the body. These are the first-order process and zero-order process. First-order process. First-order kinetics are the most common for both drug absorption and elimination. This process depends on the concentration of any given point. From a pharmacokinetic point of view, the rates at which absorption, distribution, biotransformation, and excretion occur are proportional to the concentration of the drugs. This is because these processes follow the law of mass action, which states that the rate of reaction is directly proportional to the active masses of reacting substances. Zero-order process. Zero-order process occurs at a constant rate and is independent of the amount of drug present at the particular sites of drug absorption or removal. Few drugs follow this process, for example, ethanol, phenytoin. This is due to the enzyme system responsible for the reaction. In this circumstance, the rate of reaction is not proportional to the dose. Steady-state concentration. When a drug dose is given repeatedly over a period, a steady state is eventually reached, at which point the amount of drug absorbed is in equilibrium with that eliminated from the body. A steady state is usually achieved within 4 to 5 half-life for most of the drugs governed by first-order kinetics. For example, a drug with half-life of 4 hours will be expected to be in a steady state after more than 24 hours of infusion. The pattern of drug accumulation during repeated administration of a drug at intervals is equal to its elimination half-life. When drug absorption is 10 times as rapid as elimination, as the relative rate of absorption increases, the concentration maximal approach 2 and the minimal approach 1 during the steady state. Redistribution of drugs. This phenomenon is well illustrated by a consideration of the pharmacokinetics of thiopentone. When this lipophilic agent is given intravenously, it diffuses rapidly into the highly vascular, lipid-rich CNS and brings about immediate anesthesia. However, this initial blood-brain equilibrium becomes disturbed as the drug equilibrates more slowly with other tissues, and so some drugs diffuse back from the CNS to the blood to create a new blood-brain equilibrium. A continuation of this process results in recovery from anesthetic as transferred from brain vascular tissues and eventually to body fat, the least vascular tissue. Redistribution is, therefore, one way in which a drug action in the body may be terminated. It is unusual in that the drug is still present, and chemically unchanged, in the body. It is rather a dramatic example of a consequence of the different rates at which drug concentrations in compartments of the body come to equilibrium with the plasma concentration. Consequences of uneven distribution. The mechanisms described in the preceding sections contribute to variations in the concentration of drugs between different locations in the body at equilibrium. Such differences can be revealed in living animals that undergo whole body scanning after administration of the radiolabeled drug. Alternatively, tissue samples from dosed animals killed at various intervals after dosing can be analyzed for drug content. In the case of an antimicrobial agent, tissue studies reveal whether or not adequate therapeutic concentrations are achieved in all organs. The concentrations of drugs present in tissues at known time intervals since their last dosing, established by so-called residue studies, is essential to the setting of withdrawal periods, for example, the time which must elapse before the slaughter of food animals for human consumption. The withdrawal period does not define the time between the last dosing and the total elimination of the drug or other substance. It defines the time to achieve a concentration that, if extrapolated to the basis of toxicological studies, would have a high probability of being without adverse effect for the consumer. If the capacity to bind or sequester drugs at sites other than the site of action, so-called sites of loss, drug acceptors, or silent receptors, is considerable, then it may be necessary to give an initial large dose to satisfy this need. After this loading dose, smaller maintenance doses may be all that is needed to continue a constant level of response. Finally, it is possible that a local, high concentration of drug might be disfiguring. For example, nitrofurantoin stains developing teeth yellow, or even of, for example, chloroquine causes retinal damage, or even of forensic value, for example, arsenic and heavy metals in hair.